Essentially comprised of the Right to Food campaign and the People's Health Movement India Jan Swasthya Abhiyan on children's right to food, within which then, and we are also, many of us are practitioners, I am particularly so I've been linked with NGOs and I've always worked on the ground in slums, on construction sites, trying to build programs through various social organizations, civil society organizations, which have then created models for government to look at and for the policy advocacy to basically, find evidence from and draw upon, so that when policymakers say, where does it happen, how can it happen, what would make it happen, we have something to show for it. So it's basically been model building exercises in a variety of ways that one has been engaged with. But at the same time, about 10 years ago, during all this kind of constant struggle for just basic minimum rights, rights to water, housing, shelter, and basic health rights, that we saw that there was a fairly sudden, at least for us it was fairly sudden, advent of and a thrust on severe acute malnutrition, which largely flew in from the experience of the African continent through WHO, UNICEF essentially, but also many big medical NGOs, very highly respected for me. I think they're very, very sincere and very well-respected NGOs like Doctors Without Borders and many other international institutions who subsequently came in on the back of this. Now I'm going to start calling it SAM as it's usually known. So it was the first time that many of us, I've trained as a pediatrician 30 years ago. So at that time, these terminologies didn't exist, and so these were new things for us also to learn. And in a sense, they were welcome, because what they did was to raise the profile of malnutrition, something we'd been struggling for years and years and decades, and it suddenly gave it a big thrust, like almost a kind of a rocket going off. So welcome in some sense, but also going off in the wrong direction for many of us in another sense. So what it brought with us, was a very strong kind of a medicalized kind of understanding of this malnutrition, again largely from the African experience, requiring medical treatment and being a very urgent situation. And for us anyway, inequity and inequality was a social emergency, but describing this as a medical emergency because it was associated with high child mortalities, and therefore it needed quick, immediate, quick fix kind of cures that only technological interventions of the medical variety could really bring in. And we were uncomfortable with this, but we didn't have the, in inverted commas, evidence to deal with it really, and we were not sure why also we were, we were pretty sure why we were uncomfortable with it, because it was not dealing with the social determinants, it was not looking at the social causes and so on, some things that we understood very clearly in our experience on the ground and also in our experience as practitioners. So now to come back to some of those issues about mortalities and, so this was a background within which then I might say that we have tried to understand this domain quite scientifically and quite rigorously as social scientists and as also as public health professionals. I think one gets the greatest kind of liberty as a public health professional to do it excellently, and we try to do it quite rigorously to understand and also to create arguments in support of the perspective that we carried, which was, but also to investigate it continuously in the field to see, were we wrong? Were we wrong? Is it really a medical emergency where all children, millions of them, would need to get into a hospital or a facility and to be needed to be treated in a very special way for which human resource is not available? Is it that kind of a medical emergency? Have we been wrong all this while in our experience of decades of how malnutrition in India should be tackled? And again, I am focusing a bit on childhood malnutrition. The presentations were also linked to childhood, whereas it's not the complete piece, as we well know. Subsequently, I personally and the organization PHRN has gone on to deal, to work extensively with women and women's groups and SHGs in particular through Pradhan and its networks on the ground, many districts and so on and so forth. So we have learned a lot during this, and I'll just share some, as I said, some summary learnings if I have the time. So we all know this slide. I think it's a very familiar old slide, just to say that malnutrition is in the background of almost 50 to 60% of all child morbidities, and some more than others. And in India, it would probably be, could even be more than that. Things that children die of, there's a high background of malnutrition. But when you look at mortalities, and this is one of the puzzles that we always had in our minds when we looked at the data, and there was data in the Lancet, there were 2 Lancet series around all this, and they said the kinds of mortalities they were posing to us, it didn't mathematically also make sense, because we knew already that the kernel of our childhood mortality lay in neonatal mortality, and neonatal mortality was not subject to the kind of treatment that was being talked about anyway, and the backgrounds of neonatal mortality comes from gender, comes from women and adolescents' health and their own health and nutrition and so on. So if the kernel of mortality was coming from there, the numbers left over from that for childhood mortality simply didn't add up to the kinds of rates that were being presented to us. So we felt there's an over-exaggeration happening somewhere. There's something not right about the maths itself. So many children are dying, but the majority of them are dying in the neonatal period in the first month of life, leaving only so many. But if you translate the rates of, death, say 8% more mortality amongst children with SAM and so on, it's simply, and the sheer numbers in India, thousands of children like that, at the percentages that were positioned to us in terms of the prevalence of SAM, and then the mortality of SAM, and you computed that mathematically, it didn't hold good. Unfortunately, we didn't do this well enough to publish, but it was something that came up in our arguments again and again. So you can see that this is highly neonatal mortality, and it continues to be so, more and more so now. The more that we are reducing of infant mortalities, the more the kernel becomes neonatal mortality still, which shows that the residual problem is really that of the life cycle approach and gender, rather than something to do with how you manage with children who are already in a situation of SAM. But this was only one of our problems. But anyhow, what we've also learned subsequently, and now people are beginning to agree to this in literature, in published literature, even original authors of the Lancet series have revised their estimates of mortality quite recently from 8% to 2% and so on. And this is quoted in some papers that we have written. I'll give you the references of that. You can look them up. But essentially, this is the summary difference that we have seen between what was presented to us initially when this whole issue started in Africa and India. And why am I saying this? I'm saying this because this has come about as a result of very rigorous argumentation, rigorous work, rigorous kind of evidence collection, not perhaps of the RCT variety. We don't have the capacity to do that kind of work, nor do we believe it is essential to do. And we have also published in, obscure journals and so on, whatever would take our, but we have tried to continue this discourse, and through the people's movements and the campaigns and the NGOs, which I think is very critical. Perhaps one of the critical missing links even between the gap that we are talking about, between evidence collection and research and policy work, there is this whole body of practitioners that we need to involve more. So this is what we have now learned, and I'll just share it with you. In Africa, the kind of malnutrition, childhood malnutrition we are seeing is predominantly wasting, which is acute, whereas in India it's acute on chronic. So we have acute on the back of a chronic food insecurity that is leading to stunting. So it's basically wasting on stunting rather than just wasting per se. So the incidence and prevalence is lower in Africa and is much higher in India, which we know from the the South Asian enigma that people have been talking about for quite some time. The mortalities are far higher in Africa and lower in India, and the morbidities are also higher in Africa and lower in India. So what we understood, kind of instinctively, intuitively, that we have a longer period of time that we can play with, and we have a better way of approaching malnutrition than a quick fix, medicalized right now within the next 2 weeks solution, but which has no sustainability and which will also not give us any prevention. So that's what we learned, and we had now justification, because initially people were arguing against, we have been, also termed child killers at some point, that, how can you refuse this approach just simply because we questioned it, and we said that there are better approaches, and do we really need this approach, which will have an opportunity cost that takes us further and further away from the kind of approaches that we wanted. So, and now these facts are, like I said, it's not just people like us saying it, it's MSF papers are saying this, and it's also the original authors of the Lancet series are also making these observations now, and many policy documents of the WHO and UNICEF are also reflecting this kind of position now. The hypothesized reasons which we knew from the South Asian enigma is that food insecurity, inadequate healthcare remains in the African continent, but far greater gender inequity in India, which I've already talked about. The implications were that if at all you could justify, the case in Africa that you need these short-term solutions and you need them now and you need to put all your resources there and the long-term can wait and so on, I don't agree with this, frankly. But this is the kind of argumentation that we still find in Africa. At least in India, people are beginning to shift their positions a little bit towards medium-term strategies that can look more comprehensively at the business of child malnutrition. these are the references, and I mean, you might have access to them. So there's very little published evidence on community management of malnutrition. There are just two types of programs. One is the fairly medicalized program that MSF has run, a much larger scale program in Darbhanga in Bihar. And then is the Action Against Malnutrition program that I have been leading for the last, I've had the privilege, massive privilege of leading for the last 3-4 years. And both of these papers are published, and you can look at further details there. So some of the questions that, we must pose when we think of child malnutrition in India. And I purposely say child malnutrition, and I don't say just acute malnutrition, because for us, every child is meaningful, and all their situations of malnutrition should be meaningful, and so we should be focusing on stunting and wasting and underweight, all three together. As it happens, as subsequently I've tried to inform you, there's now again a sudden shift off from wasting to stunting. Now the entire research and technical community is talking stunting and only stunting, and somehow wasting has again gone into the background. When it was just wasting, we argued for a comprehensive thing. Now if it's just stunting, we again argue for a comprehensive thing. So we want to cover wasting as well as stunting, and finally a composite indicator of underweight. We always did, and we always will. So these shifts continue to happen, and now it's a shift in the opposite direction. We have to think, do we want to only cure, only prevent, do both? And I think we should not shy away from asking for all of this together. It's about time, 70 years into independence. I mean, when on earth are we going to do that? So proximal or distal determinants, or can we work both? As I said, we have the opportunity because mortalities are not high, morbidities are not that high. We do have the opportunity of working at least at a middle range, if not at the extreme distal of agriculture and so on, but definitely at a middle range of food security, of food quality, and of working on the gender issues. I would think that if you work comprehensively on the ground, it should be possible to cover a fair ground between the proximal and the distal at community level. Food and nutrition or both. Nutrition, as perhaps I didn't say it then, but nutrition is the biomedical kind of construct of the interface between the food that we eat and its utilization by the body, isn't it? But food is much more than the stuff. It is cultural, it is social, it is psychological, it is affective. If we ask ourselves, how much do we think about food on a daily basis, as a basic need? If the food was good, you feel a bit happy. If it was terrible, it really spoils your day. We think about our next meal every time, and we are people who have next meals quite automatically delivered to us. How much food means to a human being, and how much it means to be excluded from food as a social phenomenon in a village and so on. We understand that. So food goes far beyond the stuff of food. It goes deep into our experience of being human. Nutrition, on the other hand, is a much more limited view of things, where you have some food stuff, and at the same time, nutrition in the human condition, as we understand it, can only derive from food. So nutrition can not replace food in any manner in its cultural and social and so on, and nor can it be replaced by anything biomedical, unless you think that as human beings at some future point of time, dystopically, you're going to be able to live on just pills and IV fluids. So food has to be the beginning point for nutrition. There's no two ways of it. And micronutrients are just micro portions of nutrition, which then also must derive from food. So the dialectics of it is that food has to be the starting point. So I don't think that nutrition replaces food, and nor should it in our mind. Are we going to keep talking of these little silos of SAM, stunting, 1,000 days of child growth? And 1,000 days is the current flavor of the period. Now what happens to a child in the 1,001th day? Do we forget about that child if the child becomes malnourished? There's a presenter here who's going to talk about child nutrition and in school age. Now we're well beyond 1,000 days. And there's more and more research to show that it's not as though everything gets over in the first 2 years, and then after that there's no recovery from anything ever. So you don't ever need to invest again. There's now good, strong evidence out of, again, panel data, longitudinal data like ours, but much more rigorous IDRC-funded work of Young Lives in Andhra Pradesh. And it's showing that you can make a difference all through life, because the body is like that. Body has homeostasis, body has powers to recover and keeps trying to do so. So we must place these questions to us when we formulate policies, when you allocate resources. Are we going to continue to be so very limited in our view? Product-based or process-based or both? This is something that you need to think about. So thinking of all this, these are the key principles that we have basically adopted in our work, that we talk of all children, within which then we locate specificity. So we've been talking a lot about intersectionality and specific locations. my own view and my own understanding is that we must have a universe of basics within which then you must locate specifics and contextualities. So we speak of the universe within which then there are protocol, like if we are running a daycare center, I'll just show you the program briefly if I have time, what the program actually is, what the model is. If you're running a daycare center where, so it will be all children who want to come to the daycare center of the village who will come. A normal child will be treated in the way a normal child is treated with good quality care, and a child with SAM will be treated with specific protocols for SAM, but they are all in the same center. It follows the same understanding as having disabled children in your school, unless they're in so severe, a situation that they need to be in an institution. So similarly, it's the same kind of concept here. So you don't target. You have good quality basics for everybody, and then you plug the gaps for specific conditions is what we do. Community owned, child-centered, individualized. Each child is at the kind of, heart of things. Continuity of care, seamless transitions, correct criteria. These are technical things that I don't have time to get into. Rational, no gaps. And believe me, all this is very cost effective. It doesn't waste your resources when you're plugging them in the wrong direction, where you don't have the roots, but you're watering a plant where the roots are already disappearing or disappeared. Then, where are your resources going? It really, even from a cost-benefit analysis, makes very little sense. They're process-oriented, community-owned, and then we do care about institutionalization in the model that we build. What will be the HR, what will be the costs, what will be the workers' rights, and the welfare. So this is the program that I've been referring to. This is the coverage. It's 7 blocks in 4 states, and 6 of those 7 blocks are deep tribal areas in Jharkhand, Odisha, and Chhattisgarh, and 1 is in Bihar, which is non-tribal, but it's a Musahar community, so it's a Dalit community. Various organizations who have been involved, different organizations. So this is basically the project design. So we try to work with systems. So with the NRHM, the ICDS, we try to do gap filling of the systems. As you know, that those systems don't cater well to the children under 3. There's no specific program for malnutrition. There's no specific program for growth faltering. And basically, it's just not catering to prevention of malnutrition at all. So we try to work anyway within those systems, build capacities as much as we can. The second part of it is working with women's groups, and the third part is offering the direct service to the creches. And we have been trying to just basically do this to explain the model, demonstrate the model so that it can be scaled up. This is the outcomes of it, and now evaluation data has just come a week ago, and it's showing positive results, and we hope to publish and maybe talk to you in some other convention or seminar about those. So, but it's showing as an independent evaluation. These are just MIS outcome measures. Again, you can say that they're very favorable. 86 remaining normal or improving grades basically shows that you can prevent and manage at the same time through these kinds of interventions using only local, resources. So this is current situation, shift to stunting I've talked about, but there's still a predominance of the medicalized approach and quite a hesitation over community approaches, though there's a greater articulation for the need for care as a kind of major determinant. This is a logo of the program. She's a creche worker. Creche workers are from the village themselves, and she's actually just caring. Look at the smile on her face. 5 children successfully close to her body. Some are happy, some are sleeping, some are even playing, and this is how she manages her day. So thanks very much.